Ladies and gentlemen, please welcome GetWellNetwork's Chief Strategy Officer, Todd Johnson.
Good afternoon, everybody. I'm glad that you're all still with us. I hope you enjoyed some of the sessions earlier today, and looking forward to getting through a few more things here with you. In a few moments, I'm going to have my colleagues, my friends from LifeBridge Health join me. I'm going to just quickly frame what we're going to do over the next hour. You heard me talk this morning around sort of the convergence of these consumer expectations and the investments that health systems need to do to be successful. And I'm delighted to be joined by colleagues from LifeBridge Health that has gone really headfirst into a digital strategy to meet consumers across the continuum. We're going to talk about sort of the reasons why they've made those investments, right? What it means to them in their marketplace, why it can be difficult or challenging to do so, and what we expect those outcomes to be successful. So without further ado, allow me to get my colleagues from LifeBridge up on stage, and I will introduce them. All right, let me start by introducing my friends here. From that side to this, Lesley brings 30 years of experience and healthcare leadership to our panel today. She began her career as a critical care nurse and is now both the president of Carroll Hospital, but also an executive vice president for the health system, leading strategy and helping that team think forward. She's been an instrumental driving force behind the system's outstanding achievements in quality, with a focus on accountability and transparency. Tressa Springman is the system CIO. She is leading the digital transformation for the health system, really focusing on a new consumer experience, but really in the achievement of revenue growth and operational efficiency. HIMSS has named her as one of the 2020 most influential women in healthcare IT and was recently included. And she was also recently included in Becker's Hospital Review 2019 as a list of female healthcare CIOs to know. I also know that she was crushing push-ups in the gym this morning and is an amazing friend and talent. And one day, I hope we all get to enjoy her gourmet wines that she may be producing in her free time. Dr. Duran is LifeBridge Health's Chief Innovation Officer, Vice President of Research, and Chair of Radiology. He's charged with identifying, prioritizing, and helping implement the innovation strategy at LifeBridge, both analog and digital, to improve care quality and outcomes. His work includes leveraging mobile tech to better engage and delight patients outside the health system as they go about their lives. He's also building some really interesting programs to foster connectivity between the health system, the health plan, building an innovation center, working with startups, some topics that I hope we're able to get to this morning, or this afternoon now. And I am the Chief Strategy Officer, which means I get to think and I get to talk about where I think our industry is going and help to shape how we are going to meet those rising demands with our capabilities, our products, and our services. And I'm a sponge for input, so if you have ideas, please bring them to me. Lesley, before we begin, would you please tell us a little bit about LifeBridge Health?
Sure, be delighted. So LifeBridge Health is the fourth largest health system in Baltimore. It has 5 anchor hospitals that cover Baltimore City, Baltimore County, and Carroll County. We have over 13,000 employees, so pretty big, but big enough to be relevant, small enough to be really nimble and do some pretty amazing things that we're pretty proud of. So, and it is a pleasure to be here and work with GetWellNetwork, and we're excited to be able to talk to you about that journey.
Great. Next slide, please. So we talked a little bit today about this notion that the consumer behaviors are changing. We're expecting more frictionless, easier interactions. We expect things to be digital and mobile. And those that win will embrace these strategies and figure out how to meet patients where they are in their communities. Lesley, as you think about the journey that LifeBridge Health has been on over the last 5 years, or maybe even longer than that, how do you think about consumerism influencing your business, and where do you think the system needs to be going?
Well, I've been in healthcare a long time, and boy, have things really changed. And I think those of us that are willing to meet patients where they are and be able to rise up to the new demands and the expectations that patients have, the different experience they want to have, I think that's what matters most, and I think that's what we have to really keep focused on. We can't keep continuing to do things the same way we've always done them. That's not really going to get us where we need to be. I think we heard some great stories this morning to help us understand that it really is upon us to get to where patients are really experiencing healthcare and try to make that uniquely different. I mean, with Amazon, I can just pick up my phone and order something right up, and in the grocery store, oh my gosh, I don't even have to go there anymore. I could just order online and boom, it delivers to my house. But healthcare, oh my goodness, it seems like we're not there yet. And I think patients and families are expecting something much bigger and much better than what we currently offer. So we have to be in this space.
Yeah. And Tressa, as you think about offering something different or better, as a system CIO, I can't imagine what your day is like, but I would say some chunk of it is worrying about making sure that the clinical information system is operating, functioning at its best. Why are these not the tools to drive sort of this consumer era, or are they?
Well, I think when we think back, gosh, it wasn't even 20 years ago where the automation of healthcare was really in the back office space. Our users were the business office professionals, and it was bill generation. And it's only been the last 15 years where our clinicians became front and center. And just as we were catching our breath, here's this new era of consumerism, which to traditional information tech teams, that's a whole different category of users. And they're not users that they have been necessarily skilled or prepared to address or lean into the needs of. And as many of you know, we've really spent a lot of our dollar and time, right, wrong, or indifferent, on these mega EMR implementations. And those need to work. That's a utility play. We need to count on it, but it's not going to help differentiate us in a consumer environment.
Yep. Yep. And Dan, what do you, as you think about innovation, right? I think healthcare technology, in my mind, has always lagged 10 years behind other industries, right or wrong. I think maybe I'm right, sadly. As you think about this next generation of innovation in healthcare tech, how will you know when we're there? What is it that you'll feel as a system that will tell you we've really figured something out here?
So I don't know if it's something that I would feel as a health system business person or executive. It's more something I would feel as a provider or patient, that I wouldn't feel the divide anymore between the rest of the world and my consumer experience and my worker experience, my customer experience out there, and then healthcare, which is so different. And we're not the only part of society that has this issue. Governments have this issue, justice systems have this issue, but we're not in great company, and we want to progress to a point. We want to progress to a point where you don't talk about going to the hospital or navigating a fragmented health system like it's a really expensive version of the DMV. Yeah. Right? We want to be in a better place than that. And that's when I think we'll know. So if you think about the healthcare innovation cycle historically, it was drugs and devices, and it was a process metered by the FDA, and it's a 12 to 15-year process from device or idea discovery to implementation. And if you just go back one revolution of that, 15 years ago, society didn't have the App Store yet. iPhone hadn't been invented yet. It was just about to be invented. Social media was really in its infancy. AI was something that people weren't even talking about. They were talking about in the 70s. They'd stopped talking about it. So all this explosive growth that has happened and innovation in areas outside healthcare, which is now coming into healthcare, it has all happened, along with high tech, right, within what was traditionally one revolution, the amount of time it would take to get one good idea to market. So no wonder it's been so difficult. But we are learning. I think things are changing. We have tremendous infrastructure. The societal pressures or imperative around this have never been greater. So I think we'll know we're there, if we ever get there, by that lack of a difference between us and the rest of the industries that are out there.
Right. And Lesley, if you think back, I don't know when you began to socialize this idea of a digital sort of cross-continuum approach with the executive team and the leadership team. Like, what was that discussion like? Was this a hard sell? Was it an easy sell? How did your peers think about it? And how do you begin to think about measuring success?
You know, that's a good question. It's a hard sell and an easy sell. On some level, it's easy because don't we all want to have an amazing patient experience, right? We want to be able to have our patients feel something different when they walk into any one of our facilities. We want everybody to know where they're going to park well, to know where to get to their appointment on time, and to have an amazing experience while they're in there. We all want that. But the revenue the money that it takes to make that happen, the infrastructure that you need to make that happen, the ability to bring everybody together around a common goal across, 4 or 5 different campuses, wow, that gets a little overwhelming, right? But I think the thing is first to understand that's our guiding light. That's where we want to go. And then what do we need to do to mobilize ourselves around that? So, I think a couple of things that were no-brainers for us is we have employees, we have physicians, and we have patients that experience each of our facilities. So wouldn't it be amazing if no matter which one they entered, the information was coordinated, it felt the same, it looked the same. So it became obvious to us that it was difficult for one of our hospitals to have a technology and the other one's not, right? So coming together as a system around something that powerful became a motivating force for us. And then certainly GetWell in this space, with all the different platforms you offer, was something that it was easy to coalesce around, without a doubt. The tools like the inpatient tools, the rounding tools, and Loop. Oh my gosh, Loop. That was amazing because what we've learned is it's not enough just to be connected patients in the hospital. And that experience alone isn't enough. We've got to be connecting with people before and after, and it has to be that ongoing relationship because that's what's going to bring patients back, and that's how we manage the whole care experience in a much better way.
When I think about why we want to do these things, there's this wonderful, yes, let's do the right thing for patients, right? Let's do the right thing for our clinicians. And then there's the business side of this. Right. And sometimes I think about who are we competing against, and sometimes I think about who are we competing for, right? And from the C-suite, how do you think about reconciling these investments economically? Where's the win? Where does the business benefit reside in these investments?
So I'll tell you, we've spoken a lot. I'm sure many are aware that Maryland has a unique reimbursement system. So in the old days, some might say the good old days, more volume meant more revenue to invest in something like this. Well, change that messaging and you have a fixed revenue. The only way to get additional revenue is gain market share or have amazing patient experience, low readmission rates, great HCAP scores, all those amazing things. Well, without a doubt, this is the right thing to be doing. So it's easy for us to then align the C-suite around, wow, tools like this make the patient experience better. That drives the HCAPs up. Hopefully we can really work on coordinating education and discharge so patients aren't being readmitted multiple times. And all those things together, we've talked about it a lot, seem to bring those numbers, those key metrics we're looking at into order, which then gives us incentive money to reinvest, right? So then that helps the economics better.
Yeah, great. Tressa, I don't know if you remember this, but I think it was 3 years ago, you and I were in Jackson Hole together for a really small conference, and we went out to dinner with my wife, I think. And there was, lunch. And we had a modern healthcare magazine, like one of the industry rags, and there was an advertisement in the middle of this magazine for literally a table that you put a laptop on that a clinician can roll to be between the clinician and the patient. And the company was marketing it as a patient engagement innovation. And so I often use that story, and I took a photo and laughed with all my colleagues around it. The word patient engagement and what is patient engagement sort of has gone through a lot of different permutations, and I'm not sure we still as an industry have kind of landed. How has your evolution around that terminology changed over time, and what do you think it means today and going forward? Or is it still a table?
It's not a table, no. You know, I think what we've all learned is that the experience has to be personalized, and it needs to be personalized by the patient and by their situation. In fact, no two patients necessarily have the same desires or preferences, and even depending on the care situation they find themselves in, their preferences in that circumstance may evolve into an outcome that's a different experience. So, look, we struggle to just come up with uniform ways. We hide it potentially under the guise of best practice to deliver something consistently or highly reliable. But the reality is that both the experience of our users and our consumers needs to be incredibly personalized and needs to be driven by them. From where I sit, the specific challenge that's created, and I don't know how many kind of technology, IT type people are here. I think a few, yeah, for sure. You know, we started in a world of best of breed systems where the lab and the pharmacy, they all had something of their preference. And we learned and evolved over time to what was a more integrated approach. And about the time we were looking at tables in Jackson Hole, I felt as though there was a continual stream of people coming through my office and our division with their own app. Everyone had their own app. You know, I think a couple months we looked at like 5 diabetes apps, and you know, everyone had their pet app or their favorite. And you know, when you take it from the point of the consumer, that can be incredibly confusing. And so I appreciate the fact that this partnership between HealthLoop and GetWell has allowed, at least for our organization, to have a single consumer-facing digital platform. And so, yeah, we're going to be plugging in things or allowing our patients to plug in things that personalize their own experience, because I think in the future, that's what it's going to be. It's not just going to be what we choose to push to them, it's what they choose to connect to us. But by doing it through a standard and an integrated digital consumer-facing platform, it will reduce some of that noise and some of those inconsistencies.
Great. And that's a perfect tee up, actually, Dan, to you, which was this morning Michael had a slide with like 100 different companies on it. There's probably 10 times more innovative companies in the marketplace than were on that slide.
And he knows all of them.
Yeah, well, and that's the amazing thing, right? You're getting hit. I can't imagine what your inbox looks like. It must be, 2,700 promotions a week. How do you begin to even synthesize all of that and make decisions around where you want to place your bets?
Yeah. Well, I think we have sort of a emerging governance process around this that involves everybody here, along with some of our other counterparts, shaping what the system priorities are, how the customer experience, patient experience, how that needs to look, and then that creates a set of functional requirements that we can then walk out to the marketplace and say what's out there. But having a partner that has a cross-continuum offering to begin with is, very reassuring. And as Tressa mentioned, we've gone from a situation of maybe 3 or 4 years ago having this constant stream of apps. If you create and service people's needs with a standard app, like a Loop, and people have a good experience with it and you can prove that to them, then that becomes a way of getting out of a lot of those conversations. At least that's the first conversation. So we don't get a lot of that Me Too app, I got one, I want one for diabetes. We get a lot less of that from our specialists now.
And why do you think that is?
I think it's because we've created some successes, and by providing a resource, we give them the assurance that we're not ignoring it. But also because we've been thoughtful about the perspective of what we're trying to create for the patient. I think everybody's a patient. Everybody has patients if they're in medicine. Everybody has family members who've been a patient. I've never heard someone who doesn't get what Lesley referenced, which is we don't want to kill people with options. We don't want to love them to death with 50 different apps. Because the same issues that I have with my inbox, which, I don't know if you're logging onto my inbox and looking at it, but it is a nightmare today. And it'll be a real nightmare after an hour on the stage here. I think people realize your phone's full of apps. There's all this noise, right? This is the new reality. It's now we're drowning in choice. We're drowning in convenience. We're drowning in options. We're drowning in data. Doctors realize that. So I don't think they actually mind the focus and the assurance that we have something that's worked for others that might work for them. But there are still gaps, right? There are gaps that you guys don't cover yet, and gaps that ultimately you won't, because you have to stake out where you're going to focus too. And that's what I do. I guess kind of, I've heard people liken it to like sifting for gold. I'm kind of out there. There's all these different ideas. I mean, there is a method to the madness. We use like a CRM to track all of our many startup contacts. My team will be in contact with 500 startups, like actually in person and taking meetings this year with them. We will have well beyond 1,000 reach out to us, and you just got to do your best.
It's amazing. Lesley, what do you think about this patient experience that you are building towards, that we together are helping to build together? And do you think it's going to be a true competitive advantage in your market, which is so competitive?
Mm-hmm. I really do believe that it will, because especially if we continue, which I know we will, to make the investment to implement that more fully across the entire system, as well as in our physician offices and in the full continuum of care, that's going to make a difference. You're going to want to be in one of our hospitals. You're going to be in one of our offices, because you're only going to fill out that form one time. We're going to know about you before you even get there. And I think as much as we in the industry all want to get there, I think what differentiates us is those systems that actually invest in that. Dan, he's our Chief Innovation Officer, and he has a whole team of people. That's a statement about the investment that our system is willing to make to try to be in that space and create that different kind of experience at a time when margins are thin, right, and resources are precious. So, I think it's going to make a big difference. If it doesn't, I'm not going to sleep at night and probably wouldn't be here again.
For the audience, my own personal perspective, this has been a unbelievable partnership working together, and we work really hard, right? We have a lot of irons in the fire. That means a lot of change management, a lot of disciplined project management. One of the things, there's I think two things that I genuinely appreciate about as being a partner of yours is every time that we set out to do something together, we start with outcomes in mind, right? Where is it that we're trying to get to together? And it's frequently the case we don't get there on the first shot, but we know what success looks like, and there's shared investment and skin in the game to get there. And the second thing, and the reason I bring it up is, Dan, something you said before is, you guys have been very good at challenging us to say, where can we depend on the GetWellNetwork to provide for us capabilities, but where do we need to look elsewhere and help us understand the parameters? And if you're working with us on other innovation projects, that framing is incredibly helpful to both parties because it allows us to point our energy. When we talk about the change management and what it takes to do this, Tressa, what do you think are sort of the critical elements to make that change happen, to like get all of the moving parts moving together?
Well, I was first going to say that I absolutely knew day one that you weren't going to agree to do eligibility checking. So
we got whitewashed. What's the term?
Yeah. You had a whiteout.
Whiteout.
Do you mean from change? Do you mean we as an industry, or
no, you as an organization?
We as an organization. Yeah. Well, Lesley was mentioning, and I know everyone in the room feels the tension and pressure about the pace of change today. And one thing that I think as leaders we need to be really mindful of is that you can set a vision, but if you appropriately don't bring people along, that you aren't going to get any sustainability with it. And we've tried to be very intentional about an implementation, an enterprise implementation of Rounds and Get Well Inpatient and Loop in a way where we are doing our best to break it into small pieces, to drive it based upon what matters most, and then really to not ignore the human element. And I'm the first to say that technology teams are usually pretty good at project managing and implementing the tasks on their work plan that get them from, requirements to go live. But we aren't always as good about the change management element and bringing the people along. I can't say we've totally nailed that yet, but it's a very active conversation at LifeBridge. And it's really a conversation that reminds us that because of the costs, because of the economic constraints on us, when we do make investments like this, we need to really get that value out of it. And we can't just dump it in and walk away. So whether it's deep vendor relationships, such as what we are honored to have with GetWell, combined with different ways of looking at things, added to by eating the elephant in pieces, and being really mindful of all the change we're asking the folks in the user community to tackle and take on. I think it's a combination of all those elements, and I can't say that we've nailed it, but I think we're getting a lot better and more mindful about the human element of this change, and not just getting through the to-do list.
I would just add to that, I do think that there's, and feel free to disagree with me on this one, we can have a couple of disagreement on stage. I think there's a different, there's a different feel to this work around experience, right?
Oh yeah.
Because what brought the healthcare workforce into healthcare, they could have chosen any industry, is some component of empathy for patients. Like they want to make this time better. And I was a radiology chair, so I've done IT implementations. We've worked together on things that are a little bit dry, like the radiologist workflow. They got to have something, PACS, they got to put the images somewhere. It's hard to get some people get passionate about it, but not everyone's going to be passionate about it. But I see a different feel to the sustainability and excitement around these projects that are all about fixing what in some sense has become broken, which is the transactionalization of medicine that's happened over the last 20 or 30 years, and people experience it through IT. This kind of like undoes some of that. I don't know. I feel like it's easier to engage people on this.
So I am going to agree with you.
Yeah. Okay.
This time. I think some of that is, and either you or Michael mentioned it this morning, and I know there are a lot of clinicians here. I think this really empowers some of our clinicians because they too understand that the majority of their patients can't evaluate their clinical care, but they absolutely can express how they felt. And our clinicians who work really hard every day may not be able to necessarily get the attaboys from their audience for that job well done, but this helps them get some of that back when the experience is equally fantastic. Did I just agree with you?
I think you did.
Look at this.
I mean, we got to do this more often.
Yeah.
If you guys could just.
What has the sentiment from your clinicians been? Lesley, what do you hear from the people on the unit floors or the people in the care management groups? How are they responding to all this change?
I think first it does become, oh my gosh, this is another thing that we have to do or monitor or learn to do. But I think quickly they understand the why, and they see the progress that the tools are helping us make. When a patient is able to nominate a nurse for Daisy and a great job, that the staff loves that. When the nurse is able to assign ahead of time educational tools for a patient, that's great. I can just go in and click on those and get my patients set for the day, and that's all documented for me. I don't have to remember to do that. And then things, just even service recovery things that a patient might be on a call light for can be entered into the system and taken care of. I think that starts to help the caregivers understand that these are time-saving tools, and it also, for the patient, creates a great sense of, wow, these people know what they're doing. Everything's communicated, everything's coordinated. And I think that sets up a good patient experience, and then the clinicians feel really great about that. That's another fire they don't have to put out. So although it is it's definitely a cultural change, and change is, making sure that we don't ignore the pace and ignore the impact to the staff is very important. I think pretty quickly, if we do a good job communicating the results and the progress, that connects people back to the why and helps them want to stay engaged and helps them find meaning in the tools, just like we see that.
Yeah. Dan, what about in the physician's lounge? You hear anything about this stuff? And by the way, silence could be a great outcome too, but what do the physicians think?
I think physicians are very focused on their own workflows, right? So those clinicians that have come up with a tool that helps them get a result they want. For example, as you know, we kind of began our pre-Get Well loop, our health loop experience about 4 years ago with orthopedics. And yeah, I've definitely had lunches with orthopedic surgeons talking about loop, talking about the positive impact it had on their patients, whether it was readmissions, also talking about the positive reputational impact it had on them personally. So a lot of those surgeons really believe that this drove online reviews in a very positive way for them, and it's one of the ways that we're starting to use it for our facilities as well. So there's awareness. It's certainly not the number one topic during coronavirus week in the physician lounge, right? I mean, it's healthcare, but there's awareness, and like I said before, I think people actually got tired themselves of constantly banging down Tressa's door with a different app. I mean, I think everybody understood that was sort of a prisoner's dilemma, and we had to have a common platform. And I literally, I don't want to say there's never any pushback, but when I send Adam, who's somewhere in the audience here, when we go out,
Adam?
where's Adam back?
Adam, where are you?
Where's the guy doing? There he is,
Where's
way back
Adam?
there. Former co-worker of Todd's as well. So when we go out and make first contact with the chair of OB, who was new a few months ago, and say, look, here's a tool we have. There's lots of different things you probably want to use, but if you want a tool to do your prenatal diabetes care pathway and get that going outside the hospital in a seamless fashion, here's a tool, and we'll work with you to build it. For that person who's just starting to sort of get plugged into her department and had a lot of other things that she was going to think about before she came and bugged us about an app she saw, we kind of put it in front of her mind first. Hey, if you want to do this, we're going to help do it. And it's going to be a very reasonable price versus, and the integration's already handled and other people have experience with it. So it's a great place to start a conversation.
And now we've had
heard good
300
feedback.
new moms that have been on this discharge pathway
Yep.
And
since
how are we doing?
October.
Do we have the data? How are we doing? Do they love it?
I do not have data on outcomes
bet
there
Adam
yet.
knows.
That's premature. Yeah. I know the
How are we doing,
clinicians.
Adam?
The clinicians are very happy. I don't have A1C outcomes yet, but we'll get there.
So speaking of outcomes, Tressa, maybe I'll turn it to you, and I know we have a couple of data slides. Could you, for the audience, just give kind of the high-level arc of the work streams that we've done together? And I do think the Health Loop LifeBridge story goes back 4 years, and the Carroll Hospital Get Well Inpatient goes back several years as well.
Nine.
And in both cases, you guys have been excellent adopters of the technology. So give us some of that arc and share with folks kind of what we've seen in that time.
Sure. So in the slides behind me, the majority of the outcome numbers on the top line had to do with the Rubin Institute experience. And the Rubin Institute for Orthopedics initiated Loop, and it actually came through their chairman, Dr. Delanois, who I know you know well, Todd. And they brought this live just for one program. I think it was Joints in July of 15. And you can see the outcomes since 2015. At that point, the Rubin was paying for this themselves. They were so angry that other orthopedic groups in the state were really just beating them up in online reputation when they really inherently knew their quality and their outcomes were better. And so that was our first toe in the water on Health Loop. And as you can see, this is a surgical event. It was procedure-based. We've seen a 43% reduction in readmission for those cases over this period, reduction in complications. As many of you know, if you have orthopedic or even cancer practices, a lot of that is navigation. And how many surgeons do we have in the Rio now? Do you guys know? I mean, they're doing thousands of procedures. I mean, Dr. Delanois alone has like 54 patient visits a day. And so ridiculous volumes for navigators to make sure that 30 days before surgery, up to the day before, no fever, you'd had the chest x-ray, you didn't eat, and afterwards that you weren't back in the ER just because you had a little pain or some tenderness. So some fantastic reduction in call-related activities. And as many of you know, calls are asynchronous. There's a lot of missing each other when people are trying to make phone calls, and we just couldn't keep up with the need and the requirement as the Reuben grew to have navigators that allowed all of that follow-up so that we could stay ahead of readmission reduction. So really fantastic ability to give us efficiency and additional capacity. And then this extremely likely to recommend and actually social media presence for health grades that really by physician gave them some attaboys in a way that they felt they deserved, because Loop would literally, with a good patient experience, ask if the patient was willing and then push them out to do a positive review. Improvement in CG caps, et cetera. Here, in the bottom right-hand corner, under the 13%, LifeBridge didn't own Carroll Hospital. Carroll Hospital didn't join the LifeBridge family but a handful of years ago, so they were well on their way with success with inpatient. Purchased it, implemented it 9 years ago for all the right reasons, did some really fantastic work with patient experience. And we are about to embark upon, well, we have begun embarking upon that implementation journey, as Lesley mentioned, at the rest of our inpatient entities. So we're kind of promulgating in the inpatient experience across the rest of our inpatient footprint while continuing to expand our health loop. And you'll see we've got statistics here around all of our discharges, because at this point all of our hospital-based ER and inpatient discharges also have the opportunity to go home on a loop. And we're starting to see reduction in revisit, and as Lesley mentioned, that's work we don't get paid for. And those readmission numbers are incentive dollars that we lose if we're not managing them appropriately. So reduction in readmissions. Dan mentioned OBGYN. Since October, we have almost 300 new moms on this discharge pathway. Our ER discharges have led, when people leave the ER, if you think of your own experience, a lot of times you go home with questions, and almost 3,500 times we have had our nurses, some in the US and some at our call center in Israel, US prepared nurses, be able to intervene and respond when those discharge pathways surface a real care concern, or even a service recovery issue that might not otherwise have been attended to. So we're very excited. Carroll Hospital began the journey in February of 2018 with introducing Rounds Plus to the inpatient Get Well experience, and we have thus far completed over 5,000 leader rounds where our clinical leaders are actually able to anticipate and understand what might be already going on with that patient before they ever come into the room. We're really excited, and I think some of you may have heard our Chief Nursing Officer, Stephanie Reed from Carroll, speak this morning, that we're beginning to enroll our hospital discharges at Carroll onto a loop. And boy, think about the power for these patients who, when they leave the hospital, have an opportunity to dig back in, along with their family, to those discharge instructions or their care information, and be able, at a time maybe when it's not as crazy or as chaotic or they aren't feeling as poorly, to remind themselves of things that are going to continue to make them well. So we're real excited about that. Next data slide. This really just surfaces the year, kind of a year in review, and this was the year where I think it was a go big or go home between LifeBridge and GetWell. This just represents over calendar 2019 some of the higher level numbers that I think we're really proud of, and I think we're excited to see how much farther this is going to grow. And at some point, maybe these numbers will coalesce into a single number around touches, maybe digital touches or percent healthcare wallet, but this is where we are today. And I'd welcome Dan or Lesley if you would like to add anything on this one.
We want to see these numbers go up even higher. I think we're in a point today where we're just at the tip of the iceberg across all of our facilities, getting it so every inpatient interaction is done through the GetWellNetwork within the room. Currently, because of the rate limiting factor of email availability, as well as about a 30 to 40% engagement rate, we are around 10% of our total population that transitions through our ERs and our inpatient facilities being up on the loop. We feel pretty strongly that between getting broader staff buy-in by having the inpatient side that they see, and also getting to text, SMS text, which is something we're working on together, rather than email, so that people get it on their phone and are bringing it up in real time, I think it's going to be more like 50 by this time next year. So I think we're going to have something like 5x these numbers. And this is the year where we're really going to try to scale it. And it's a little bit, I don't want to say intimidating, but there's definitely like some antsy feeling about, well, all of the exception management that we need to do. So if we hadn't built the call centers, which we haven't thought much about or talked much about here to this audience, but there's been a lot of effort in our health systems to build call centers. In Baltimore, we have a branch that is in Manila in the Philippines and another one in Israel. For all sorts of different workflows, and it's all managed together by a group that now reports up to Tressa. And I think of it in terms of the loop, it lets us do all that exception management and lets us have bidirectional communication with the consumer when we need it, so we can engage them and have them self-navigate through content, but then when they need it, they can push information and engage with a human being. And that's really, really powerful, to me. Yeah. And that's what we have, we can't just be Netflix in healthcare. We somehow have to have a person that talks to you. You can't just be, have you ever talked with anyone from Google outside of a conference, right? So we have the hard job of somehow having to be both, because of what we do. And I think our ability to get where we are today and to scale this, hopefully we can come back next year and tell you we got to this 5x number. But there's no way we could do it without the call center, I think, because it backs up and services all the things that we surface. Yeah. All the stuff that becomes a service recovery opportunity, it would just be sort of like someone getting more frustrated waiting on hold somewhere if we didn't have a place to catch all that. So.
I think the people and the technology with GetWell have allowed us to make much less visible the silos of episodes of care that we continue to have.
I agree.
Right?
I would add to that, because I think that, having the GetWell inpatient, that was an amazing tool for the patients to experience. They get to see their movies and they get their education, and, the nursing documentation connection is powerful. But what's been amazing is the evolution of the additional tools, having the Rounds Plus and have that tool feed information at the fingertips of the people doing the roundings, so they could interact with the patient and already know the issues. And then the discharge planning with the loop, to be actually able to see those readmission numbers for those patients engaged in all three of those tools go down. Wow. I mean, that's the full circle moment. That's the moment where you can really further engage the providers, because they're seeing the big difference that's all making together. And I think as we continue along that journey, we've experienced some of those successes in small doses, and to be able to implement that across the entire system, that's the magic. That's what's really going to alter those numbers even further.
I think it's amazing where we are, and I too think that the work is just beginning, right? We have so much opportunity in front of us to unify these experiences for patients across settings and
I'll get to share some of that, and our product teams will share some of our vision tomorrow. In a moment, I want to welcome folks. If you have questions, we have a microphone in the middle, and we'd love to address some of those. While you're thinking about that, maybe one last topic that I didn't prepare you for. This morning, we got our hearts broken, or maybe lifted, with Michael's family. And I don't know about you, but that was awfully powerful to me. And we are going to be pushing a lot of chips onto the table in the personalized engagement for family members. And I think that we can all agree on the goodness of that endeavor. But as you think about the business impact, like, how do you guys think about the benefit, Lesley, or the impact of reaching out to not just patients, but this community of support around the patients as well?
Yeah, I think that's critical. I thought that was great to hear the vision this morning of how everything is going to evolve and the great plans for the future. I mean, I know we're focused at the moment on just to try to get some of these tools implemented in all 5 of our organizations, but we're already looking at what's the additional 2, 3, 5-year vision to more fully take advantage of all of this. And let's face it, the patient in the bed is worried a whole lot about all the family members and everybody impacted about their illness, as much as they need that support from those people. So to have the family members engaged in a powerful way, to be able to communicate to everyone, no matter where we all live. You know, many of us don't have the blessing of having all of our family members close to us, but they all do care.
Yes.
And so having tools that can connect, I mean, oh my gosh, when I saw that thing come up about the circle, I'm like, oh, that's going to be amazing, you know. So I do think that it's really exciting and almost overwhelming in a giddy sense about where we can go. But yeah, involving family members is going to be another whole evolution.
It is. Any other closing thoughts or ideas before we invite folks to ask questions? Tressa, anything else that you'd like to reflect on?
I'm just excited. I'm excited for what there is to become, you know. I've said it once, but we really are committed with GetWell being our consumer digital platform. It will connect on and off ramps to other experiences, but being able to have more of a platform play than having to address the interoperability challenges application by application is an exciting thing for us, and I think it's really going to help us close that gap for our patients a lot quicker.
Great. Dan, anything else to share?
I think they said it. So.
Speechless. Dr. Duran is speechless, everybody. Well, we've got about 12 minutes. I hope that this has been stimulating and interesting, and thank you, the three of you, for joining me on stage. We'd love to address some audience questions, either about the work we've been doing or other things that LifeBridge is thinking about. Does anybody have anything to challenge us with? Please come up to the mic. And really, if it's going to be crickets, then you just have to listen to me keep talking for 10 minutes. So don't be shy. Nothing from anybody.
Hope you're awake.
Well, you got a brave soul. Here we come.
Oh,
Thank you,
Joe.
Joe.
Oh, Joe.
Introduce yourself first,
You can
please.
only ask them.
Okay, deal. Joe Diver, Bay State Health, Director of Digital Transformation and Innovation Strategist for TechSpring, their Innovation Center. So we're in our journey of deploying the inpatient GetWell system, and we're a IDN payer, and you look at the population of our population, a lot of government payers. If you were to pick one loop or one thing to do differently for that population, where would you start?
Government payer group. Come on, Mr. ACO.
Yeah, I would probably start with a general pathway for high ER utilizers to see if you can get on their phone and get them in contact with your organization, because there's a lot of different care management pathways that might be able to splice into that. Like if you had to start with one, I would probably start with the general ED loop. if it turns out that this prenatal care piece works well, Medicaid population's a very big expense, tends to be things like premature deliveries, but I don't think we have the data to suggest that we can prevent those yet. But if we get there, then that would be, that would probably become my first answer. Right now, it would be the general ER discharge loop that we have, and thinking about how that targets the subpopulations you're interested in with higher ER utilizers in Medicaid.
I agree with that.
Great.
And Joe, we ask questions not only about their care, but their experience.
Right.
And I know you and I have talked about the fact that there's direct reimbursement, and then there's that quality-based reimbursement. And knowing that there was an experience issue, let alone a clinical issue, and being able to intervene and do something about it, even when they physically left the facility, is pretty powerful.
Yeah.
Great. Thank you
Along
both.
with the social determinants,
Yeah.
and
And we do
housing, food.
Just
Transportation.
on the loop side, I'm sorry.
No,
we
that's okay.
we definitely see less uptake of less engagement with the loop in Medicaid patients, but it's not non-existent. They, as a class of individuals, do have cell phones. And interestingly, we have seen in the 65 and up actually slightly higher engagement rates than below. Now, if you get into the 80 and up, it does taper off a little bit, but which is consistent with what I think we're generally seeing in sort of app usage. So, those are two government payer classes and how they are sort of represented in loop usage.
Great. Thank you.
Other questions?
Hey, I just have one. First of all, guys, thanks so much for sharing. I'm just struck by, you guys seem to have a unique leadership alignment at your org that I think helps facilitate some of these things breaking through and going at a pace that we haven't always seen. For those of us who are in our organizations that are large and complicated, and we don't hold EVP titles and chief titles, but we have things that we think should be driven at the organization at a high level from an innovation standpoint, like how do your mid-level managers, your manager leaders, how do they get their, I guess, ideas and breakthrough ideas up through you guys, and how does that all happen? Would love to just hear your thoughts on that.
So, I
Start
mean,
with governance.
I think we have a governance process where people are definitely encouraged, allowed, just almost made to feel it's their responsibility to bring innovative issues forward, to bring their best practices that they're hearing about forward. And then we really go through a vetting process to try to determine, what things have merit, what things need further investigation. Is there more information to be had for us to make a decision? I think Dan one time told me, my job is to bring 500 things forward and hope 2 or 3 stick. And I thought about that when he said it. I'm like, that's right. That is absolutely right, because the more he does that, the more that informs us of what's out there. Because I don't know, how many of you have time to just really be scoping what's out there and that's new and different and innovative that we should be trying amongst the rest of your work, right? That probably gets squished down pretty low. So it is fun to have an internal process that doesn't just have Dan responsible for that. It has each and every one of our leaders responsible to bring what they know in their best practice or in their sphere of influence forward for us to be able to investigate.
I think some of it's cultural, Michael. We have a lot of competition in Baltimore. We've got Hopkins right down the street, and we've got to differentiate. And so just culturally, there's a little bit more of an opportunistic, willing to take a risk here or there mindset. And it's not just at an executive leadership level, it's pervasive. So I think that's helped us move this journey quicker and really hopefully recognize and empower and raise up those good ideas, because they aren't coming from the top down usually. As we all know, the real good ones come from the people doing the work.
That's right.
Yeah, I think we have a culture where if you're one of the bigger places in Baltimore, I'm not going to do their advertising and rename them here, but I think a lot of times they're focused on things like an international or national reputation, and that drives a lot of what brings them to work every day. To be a community health system in our communities, to be very, very focused on some ridiculous disparities that just structurally exist. And it's not hard to get people pumped up to solve some of those things when you have a 20-year difference in life expectancy from one side of the hospital's zip code to the other side, to literally the other side of the street, right? And I think our leadership's just very focused on that. And you drive to work every day and you see it. Like you can't hide from it. So.
Any other questions? Looks like we have one up front. Get in the queue if you have a question, because we're going to run out of time.
This
and
is
you'll
a
miss
guy
your
with a list of
chance.
questions, isn't it?
Oh, yeah, that guy.
Stephanie, get up here.
No, it's not too bad this time. So you guys showed some good outcome data. Thank you for doing that. I was curious, my understanding was Loop was pretty new. Was that just with the inpatient product and Rounding Plus, or was that with all of those three things working together? Was that with GetWell inpatient and Loop and...
I'm sorry, can you restate the what was
Yeah,
what?
which figure? Because there are quite a
So
few
yeah,
out there.
you showed some good outcomes data in HCAHPS and readmission rate. Was that just with the inpatient product, or was that with like the inpatient product plus the Rounding Plus and the Loop
Do
product?
you want to pull data
Yeah.
one back up?
Data
no,
slide 1,
think
please.
it's-
Maybe I can do it, actually. Let's see.
There it
Boom.
is, yeah.
So for example, the reduction in readmissions.
The readmissions one is the 15% one?
43% is Rio.
That's a relative reduction,
Yeah.
right? It's a
That's
15%
correct.
absolute. So that is Loop.
Loop.
That is using an HIE tool that we have available to us through something called CRISP. That is a tool that takes an entire panel and then compares it to a similar panel in an automated fashion using a bunch of data that's centralized at the state level. And you basically give a pre and a post intervention date, and you give your panel, and then it does a comparison for you. And it's kind of the accepted bar in our geography. One thing that exists in all of these data, right, that I think is a barrier between having them on this screen and having them in the New England Journal, where we hope to eventually get them, is the issue of propensity matching. And I was speaking to you about this before. It's really hard to get the selection bias of someone who downloads this on their phone and takes the effort to do it. But as we go from 10% to 50% enrollment, if we do not see dilution, I would argue it doesn't matter.
Right.
But we aren't seeing dilution as we've gone, like let's say from 5 to 10%. The numbers up here are generally held. HCAHPS, that was a loop analysis.
Inpatient discharge, right? At the time, 3 hospitals.
No, yes, inpatient discharge loop, 3
Yes.
hospitals,
Yes.
not inpatient.
Right,
Yes,
right.
yeah, not the inpatient product.
We have just begun the journey of having our hospital patients who are being
Yeah.
discharged also be put on the loop.
Yeah.
That was the session this morning. So we're excited to know if access post-discharge to all that inpatient content will promote an even bigger reduction. But we don't know yet.
And then the
and then-
HCAHPS reduction, or the improvement in HCAHPS, was that also with all 3 products or just with the inpatient product?
So that's the inpatient.
Oh, that's what you're
Inpatient.
referencing. Okay.
Inpatient.
That's just Carroll Hospital.
Okay. Thank you.
Yep.
Thank you.
Hi. So with the utilization of GetWellNetwork, have you seen an improvement in staff retention?
Good question.
I don't think we've measured it yet.
Yeah, I don't think that, you know what, I think we're all doing so much around retention that I can't claim today that GetWell inpatient or GetWell rounding increased staff retention, but I can tell you that it certainly increased their happiness once they got comfortable with the implementation of the tool. Certainly there was a lot of positive feedback about what the tool does and how it enables them to do their work easier and spend more time with the patient. So we have that we can quantify, but not necessarily a direct correlation in improved retention by that alone.
I would say that the successes that Lesley had as president of Carroll Hospital, implementing the inpatient solution both for the patient experience and really to better automate some of those routine tasks our bedside nurses were getting burdened by, is something that I 100% believe that the clinicians, mainly the nurses at our other 3 inpatient facilities, are super excited to bring to their facilities this year. So
Yeah, I agree with that.
I think they're really excited about it, and that's very qualitative.
Yeah.
But a lot of them are here, so I don't know. Hopefully we'll get some head nods.
Thank you.
Well, thank you for the questions. That is time to a T. So thank you so much, the
Thanks,
3 of you,
Todd.
for the commitment to the work.